Hello, my name is Figen Yıldız. We'll be talking about pertussis tonight. Our objectives are outline the disease process of pertussis, including epidemiology, pathophysiology, and identify the clinical findings pertussis among infants and young children. Discuss the transmission and prevention of the pertussis. Review the treatments, but focus on pharmacological and non-pharmacological treatments and application in the clinical practice. This infection is known as a whooping cough because of the high-pitched inspiratory sounds that it creates, that is whooping sound. It goes by a Bordetella pertussis. It's aerobic, gram-negative bacillus, non-spawn forming, and humans are the only host. Endemic in all countries, affects 24 million children under the age of 5 per year, 160,000 deaths in this age group, and peak incidence infants up to 6 months of age. Spring and summer, it's increased the infection rate. And as we see on this pink line, that this shows the kids under 1 year of age, and higher in the incidence happens in this age group. And also there was a high peak in 2000, after 2010, it was a little bit decline, and now there's another peak is happening. Pertussis is a primarily toxin-mediated disease. This bacteria can attaches the respiratory tract, affects the epithelial cells, and paralyze the cilia. And this can cause the inflammation of the respiratory tract and interferes the clearing of the pulmonary secretion. Pertussis, this bacteria can create toxins, but the purpose of this presentation is we'll be only talking about the pertussis toxin. Pertussis is generally transmitted from person to person via respiratory droplets, but direct contact with the respiratory secretion from infected individual may also lead to this disease. Incubation period is 5 to 21 days. Children are more contagious during the first 2 weeks after the cough onset. And usually source is the unrecognized infection in adult with a cough. And high mortality is infants less than 1 month old. And this slide shows us the pertussis toxin, that how it affects the pulmonary and epithelial cells, and epithelial cells that have the paralyzed, and also this can create the high pressure and then can cause a pulmonary hypertension, and this pulmonary hypertension leads to hypoxia, and it can lead to sudden death syndrome with the younger children. And the clinical features are, it happens in the 3 stages, and the first stage is a cathedral stage, the 1 week to 2 weeks, and they are the most contagious in the stage. Non-specific complaints, common cold, worsening cough, runny nose, sneezing, and low-grade fever. And they goes in the second stage is the cathedral stage, second stage the proximal stage, that these classic symptoms of pertussis happens. They might have a fever, maybe, or minimal, rapid firing of cough happens in this stage, the violent cough. And this extreme cough can cause vomiting. This can occur usually at night and can average up to 15 attacks per 24 hours. And this can lead to the cyanosis, the sweating, prostration, and this coughing fits can cause exhaustion and sleep disturbance. And the third stage is the convalescent stage. This stage, the symptoms can be variable, gradual recovery, coughing is lengthened, and this stage can last up to 6 months. And diagnoses are usually it's clinically diagnosed. Please do not delay the treatment. And cultural sensitivity is lower behind the 2 weeks, and it may take up to 4 to 5 days or even maybe 12 days. PCR are the more preferable tests. They're more sensitive, rapid results done with the first week of the illness. The serology is not advised, especially in infants or the vaccinated individuals in between the past year. False positive results can occur during the cross-contamination during the specimen collection. Actually, there is a link on the CDC website that it goes through how to correctly collect the specimen. And the false negative results can occur with increasing time elapsed from the cough onset. And with the PCRs, many laboratories are requiring that the PCR confirmation, but they're not standardized the PCI assays across the laboratories. So this can lead to sensitivity and specificity can vary. Differential diagnoses are RSV, Streptococcus, pneumonia, adenovirus, reflux, asthma, or foreign body. And the pharmacological treatments are early treatments with macrolides, erythromycin, zithromycin, and clarithromycin. And these are the zithromycin doses. And if any child that they cannot tolerate macrolides, they can be used the Bactrim. And non-pharmacological treatments is no medication provides symptomatic relief for the pertussis-associated cough. Antibiotics eliminate the B pertussis from the nasopharynx to reduce the risk of the transmission. It does not reduce the duration or severity of the cough. Close monitoring required for the respiratory symptoms, and they can be under the droplet prescription for 5 days after initiating the therapy. Close contacts should be treated between 21 days of disease onset, and prophylaxis also should be offered to individuals with close contact with pre-existing health conditions. In pregnant women over 30 weeks of gestation, and avoid antibiotics in the first trimester. And if the woman was diagnosed in their last month of pregnancy, they can be treated with erythromycin. The complication, if the rate is higher, infants younger than 6 months old, it can be pneumonia. They can develop a secondary bacterial infections, pneumonia, seizures due to hypoxia. They can have encephalopathy, nosebleeds, subconjunctival bleeds due to violent cough, and also nutritional deficiency related to vomiting. They can have syncope, sleep disturbance because it always happens at night, rib fracture, incontinence, death, and activation of the tuberculosis. And we need to know when to refer. And urgent referral infants under age of 6 months with suspected infections, they should be referred. Complications can happen. They may be dehydrated. They can develop secondary infection of pneumonia. They can have encephalopathy due to hypoxia. And prevention. What do I do to protect my child from whooping cough? Keep your newborns away from anyone with the cold symptoms. Vaccinate your child. Make sure that who's around your child has been vaccinated. Talk to your healthcare provider. Keep records for your vaccination with your child. And the prevention, best way to prevent through the vaccination. Target the adult immunization, caretakers, grandparents, parents, mothers with each pregnancy. And when it's doubt, revaccinate. The vaccination schedule is younger than 6 months, they can get a D, TAP, diphtheria, tetanus, and pertussis. the schedule is 2, 4, 6 months, and between 15 and 18 months, and another 4 through 6 years old. And with the pregnant woman, they should get vaccinated with their each pregnancy. And adolescents between age 11 and 12 receive single dose of DTaP. Adolescents 13 through 18 years age who did not receive DTaP should receive single dose of DTaP, catch up as a booster or instead of the DT. 19 to 64 years old, single dose of DTaP can replace the single dose of their DT booster, and this can be given every 10 years, and special emphasis on the adults who is close contact with the infants. Reaction to vaccines is limited to local reactions. They might have a fever of 101. More severe reactions are uncommon, and local reaction more common the following after the 4th or the 5th doses of vaccination. Person who has ever had a life-threatening allergic reaction, any part of the DTaP vaccine should not receive the DTaP vaccine. And of course, you have to keep in mind that the Guillain-Barré syndrome, 6 weeks after a dose of tetanus toxoid, the vaccination. Conclusion. Whooping cough can be prevented by vaccine. Early diagnosis is imperative to reduce the infant mortality, and we have to report the pertussis cases to public health authorities as soon as possible. And suspected cases, avoid contact with the young infants, children, and the woman in their late pregnancy. Any questions? Test question 1. 3-year-old male patient who's been sick with the cough for 2 weeks with starting a vomit after inspiratory whoop. The most likely diagnosis is tuberculosis, RSV, Bordetella pertussis, or the croup. And answer is Bordetella pertussis. And second question, what is the antibiotic of choice when treating an infant with the pertussis? A. Amoxicillin, zithromycin, tetracycline, ciprofloxacin. Answer is zithromycin. And these are my references. Thank everybody listening my presentation. Have a great night. Thank you very much.